So, let's discuss the early diagnosis of significant prostate cancer using multiparametric MRI. How good is it? No conflict of interest? Okay, if you look at the literature, everything is fine. The sun is shining, blue sky. We have 2 level of 1A systematic reviews. We have a 1A level of prospective clinical randomized trial. And we have multiple level of 1B studies, and they are emerging every week. So, it's good, isn't it? And it has been shown that one of the most important things, and I think all the literature agrees, that multiparametric MRI compared to truss biopsy has a lower detection rate of insignificant prostate cancer. And has an even higher detection of significant cancer. Nice meta-analysis. Furthermore, it has been shown also that we can better grade cancer using MRI. Undergrading of significant cancer with truss biopsy is significant, 46%, whereas with MRI it's only 5%. I must admit this is one of the first publications, so probably it's a little bit less good, but it is a lot better still than truss biopsy. This is a question a urologist is asking you. Do you miss significant cancer with MRI? And that's what they are afraid of. They don't want to miss significant cancer because then the patient can die. And that's the worst thing that can happen, isn't it? The answer is yes, we can miss it. No technique is perfect, isn't it? We miss 2 to 11%, depending on population, depending on radiologist, depending on your situation. And if you look at this nice publication of various expert authors, you can see that the negative predictive value of those guys is no. A little bit less is the AMET study, the PROMISE study. It's a little bit lower, 89%. And if you look at the criteria of Gleason 3+3, it's even 75%. But this was done on a 1.5 Tesla machine, without pirates and with community radiologists. I will come to that a little later. But in expert hands, you can see the numbers are high. Where do we miss cancers? What's the area where we miss with MR biopsy and with truss biopsy cancers? Well, actually, with MRI, we are missing them at the apex predominantly. At this area, it's difficult to get the stick with an angle to the rectum. It's painful for the patient. So this is the area where MR-guided biopsy is missing most of the tumors. And, well, with truss biopsy, of course, it's the anterior part where tumors are missed. This is important to know. Okay, now, in 1954, you were using a finger and you could feel a hard lump. And 95% of the tumors have a hard lump, a serous cancer. Whereas 5% are medullary tumors. Now, in 60 years later, we see a hard lump. We see a hard lump by the black hole of diffusion-weighted imaging. And it's about the same. We miss 5%. We miss the medullary, the mucinous tumors. In addition, we are very bad at 3+3 and 3 plus a little bit 4 tumors. We can miss them, and those are the insignificant tumors. However, if an insignificant tumor of 3+3 has a large size, it can be a significant cancer. So this is what we miss. You should be aware, the 3+3, the 3 components, sometimes is very hard to see. Sometimes you see it, but most of the time, and that's good, because we want to miss insignificant cancers. I will come to that a little later. 75% of the tumors that we miss are these tumors. And of course the mucin tumors, those are the high-grade tumors which we miss, the 5% of the non-hard lumps. And you can see that this mimics normal prostate tissue. So be aware that you can miss something. If you miss a tumor, then in retrospect the tumor may have been there. So most of the cases it's a misdiagnosis or it's a missed biopsy. If you look at the Padhani data, they missed 15 tumors in 223 patients, but 10 are missed due to a wrong biopsy. They were recognized on the MRI. This was one of the patients I read with Les Thompson with Padhani study, and he said, Jelle, yes, are you sure that there's no lesion? I said, yes, I'm sure there's no lesion. Does anybody see a lesion? This was a Friday afternoon case. Around 5 o'clock I want to go home, but if in retrospect, there is a lesion here. It is enhancing, a small tiny black hole on the bead 1400, it's white, and this was a significant small cancer. So misdiagnosis. So you may ask yourself, should we double read the negative cases? But that's another story. Okay, now the message was, do we miss significant cancer? And we don't want to miss significant cancer, but what is worse? Missing a significant cancer or not finding finding an insignificant cancer? So if we are looking with a high specificity, we probably will miss some significant cancers, and we will just increase the number of insignificant cancers that we do not want to find. The reason that the PSA screening was not allowed in the US was not that we were missing significant cancers. No, it was that we were finding too many insignificant cancers, which is harmful to the patient. If I have an insignificant cancer, Jurgen, and if you see my MRI, don't tell me, because I do not want to know, because I will not die from my insignificant cancer. And if I know that I have an insignificant cancer, I look at my prostate, say, hey guy, well, when are you going to be significant? And before I know, my prostate is in the bucket of the urologist. And I'm wearing diapers. So, be aware that this is important. So what do you want? Miss a significant cancer or not find an insignificant cancer? This was a nice study in Yama, and if you do additional biopsies, urologists want to do additional biopsies to the targeted biopsy on MRI, then you see that you see a lot of more cancers. You see, 103 more cancers out of the 1,000, but 83 were low risk. And you need to do 200 trust biopsies to detect one additional significant cancer at the cost of 17 patients with an insignificant cancer. So this is important. Now, you have to take into account the clinical scenario. In a biopsy-naive patient, you should do high specificity reading. If you're in doubt, it's no, because you do not want to detect an insignificant cancer. However, if the urologist has been sticking many needles in a patient and if the PSA is rising, you do want to find a tumor. So then you do high sensitivity reading. So this is important to know. In addition, detection of significant cancer depends on the quality of the MRI and the reading of the radiologist, the population you are looking at, and finally the definition of significance. What's the definition of significance? Can you tell me? Well, if you ask a urologist, and if you look at the urology paper, you can see these are the definitions from the urology point of view. And I'm forgetting the pathologist and the radiologist. So we can discuss forever what is significant. 3 plus 3, 3 plus a little bit 4, well, all kind of criteria. So this is a problem. For me, significant is I recognize it on MRI, and insignificant I don't. Another thing, not all radiologists do it well. Yeah, I think the urologist is correct. So, part of my presentation will focus on this. This nice paper of the next speaker showed that there's a variability. You can see that the detection rate of significant cancer can be low. It can be good. Negative predictive value can be low. So there is a variability in the quality of the MRI and the reading. That is important. Furthermore, this is also where urologists really want to make an emphasis on, is that there is a large variability of the negative predictive value. This is a large group who evaluated the MRI, and based on this variability, it is not in the guidelines of the urology. The variability of acquiring interpretation and biopsy should go down. Furthermore, if you look at the PIRATs, it looks good, doesn't it? Nice sensitivity and specificity. With PIRATs version 2 it's even better, but look at these data. 36 to 94%. What a variability. Detection of significant cancer. If you look at the literature in PIRATS 3, 13 to 71%. Well, with PIRATS 4 it's less, and with PIRATS 5 it's almost always a tumor, but the variability in PIRATS 3 is high. Again, this is what I showed before, and you can see that if the training is not well, if the technique is not optimal, you will have lower results. This is also emphasized by Jurgen, who was the former chairman of the European Society of Urological Imaging of the EAU, and he said a negative MRI does not guarantee the absence of tumor, so of a significant cancer. And this study was performed by community non-trained radiologists, and if his radiologist, well, did it, and he did it, who was trained, the results were a lot better. Furthermore, this is from the US, the other side of the ocean. The inappropriate use of PIRATS version 2 by new users who do not have sufficient training or experience is damaging to clinical care. If you can't do it, don't do it. Like anything in life. This is a case which we had, a case we see too often. 65-year-old man, PSA 32, 2 times negative thrust biopsy, stage T1C. So, okay, report suspicious central zone lesion, biopsy of this lesion is advised. Well, first of all, this is not a central zone, but this is probably a transition zone. It looks like a well-marginated tumor, so it looks to me like a PPH. I would give this a PIRATS 2. On the fusion, a PIRATS 4. On the sagittal image, it's also PIRATS 2. So this is a PIRATS 2. No needle is needed. Luckily, the patient came to our place and we were looking at the images, and I think it was Jurgen who found something over here. You can see here in the peripheral zone a tiny lesion, and that had restriction. There was a B1200. And Joe, what do you think about the image quality? It's crap. It's not good. You can't make a diagnosis on this terrible noisy image. Image quality is too bad. So this is not according to the rules. The rules prescribe a B1400. And this lesion appeared to be a Gleason 5 plus 4 is 9. Okay. This is what we see too often. How to be good in detecting significant cancer? First of all, training. Teaching radiologists, but also urologists. They also need to know about the black holes, because they are doing also transfusion biopsies. There is a need, there is a big need. If you give a course at RSNA, it's sold out within one hour. There is a queue already at 7:30 a.m. in the morning, and the room is packed, and this is what we have. Now, this is my concept of the circle of learning. First of all, you have the teacher. Second, you have the unaware, incompetent student. And the unaware, incompetent student should become an aware, incompetent student, because then she can learn. And if she learns, then you are aware, competent. So she doesn't have the book anymore, and she's just looking at the others, trying to teach. And then this is the person sitting a little bit at the back, unaware, competent. That's dangerous, because again, if you're unaware, competent, you may also you may make some mistakes just because you are not that much focused anymore. Okay. Now, what about training? This is a nice paper of Barentsz from the group in Washington, and the specialists had less PIRATS 3 diagnosis. PIRATS 3 means I do not know. Specialists were defined as having read more than 2,000 cases, and you can discuss this, but this is what Greer and Barentsz said. And a non-specialist, that was 300 to 500, and there was a significant difference. So, okay, a paper in the Journal of Urology, assessing the value of MRI. What's wrong with this group? What's wrong with this paper? Look at the data. Anybody see it? This is a well-known group and a well-known journal. Well, you see that here, the PIRATS number of diagnosis is 40%. Can you imagine that in 40% of the cases you say, I do not know, and that you are publishing these data? Okay, it's honest, but okay. So the other thing is trained technicians. We need to have good images. That is very important. It's just like mammography. We need to have a specialized prostate technician who is training others. We have to use PIRADS. We have to use double reading of perhaps PIRADS 1 and 3, the negatives, to be sure, and or computer-aided diagnosis, and in the future artificial intelligence. This case I've already shown. With double reading you will find this tiny tumor. Another thing is quality control. You have to be very critical on your own performance. Go to your multidisciplinary team and look at the results of your MRI and what comes out of the biopsy and the prostatectomy. So be critical. Go to the MDT, and if you have PIRADS 4 or 5 lesion, and if you have a negative biopsy result, ask yourself the following question: is my technique good? Is my interpretation correct? Is my biopsy correct? And again, in Padhani's study, 10 of the MR biopsies were wrong in the false negative cases of significant cancer. So this is important. Then finally, if this all is good, there is in PIRADS 4 a number of patients who have at least a 3+3 or granulomatous prostatitis or some other things which mimic prostate cancer. I think in the future we should also have an external quality control by a reference center and certification, just like with breast. But this is also a political issue which can vary from country to country. It may be easy to implement it in my country, it may be difficult to implement it in the neighboring country. So, but I think we need to think about this because this is important. Now, the guidelines prescribe the following route. And just imagine that you are a patient with a PSA of more than 3. Wim, what would you like? Would you like the finger of the urologist plus 12 or 15 needles, which can miss the cancer in 40%, which can overdiagnose your insignificant cancer in 40%, or underdiagnose your aggression, which will give an underestimation of your true tumor? Well, that's not really bad, because there are nomograms, you know, nomograms, and they're good. They can predict the risk of tumor. Well, rubbish in, rubbish out. The T stage of the finger is bad. The untargeted biopsy is not good, and the PSA is unspecific. So that is fed into nomograms, Parton nomograms, Caton nomograms, whoever made them, and then you have low risk, intermediate, and high risk. And well, most of the radiology community and urologists ask for the bone scan and an MRI, not whole body MRI. You've heard the story of Anwar Padhani. He's not really in favor, I think, of the bone scan. This is being then well discussed in the urology team, in the MDT, and then finally the patient has a diagnosis. Would you like this? This is the guideline, by the way. So, be disruptive. That's me. I like to be disruptive. So what we did is, with our urology team, we have the following scheme. And it's supported by the healthcare providers. GP referral, 3 nanogram, so elevated PSA. He's going to an expert center, is seen by a physician assistant, not by a urologist, and the first thing is a clinical risk estimation and an MRI. If the MRI is negative, the patient is discussed in a small MDT. It's also the risk of the patient, the age of the patient, etc., etc. And if you have a PIRADS 1 and 2, the patient is going back to the GP. This is about 49% of all the patients. So those are the patients with either the negative or the insignificant cancers. The rest of the patients will have a targeted biopsy, either with transfusion, or if it's a small lesion or a difficult place, direct in bore, and you can see that there is 8% which is negative. That will go back to this group. There will be a surveillance of all of these patients. At least 1 year later, their PSA need to be evaluated. If it rises, you will repeat the MRI. These patients anyhow get a repeat MRI. So then you have the 38% patients who have a new nomogram. It stages by an MRI, a targeted biopsy. You can have some other markers as well. And then you have the stratification in low risk, in intermediate, and into high risk. Now you can see that the number of low risk is only 13%, whereas it used to be 50%. So there is a drop of low risk patients. So I think Jurgen can skip his presentation because active surveillance will not be done in the future anymore if we just send the patients home here immediately. This will only be a minor part of the patients. Intermediate and high risk, you really should evaluate them very well. You know that I'm a little bit fond of nano-MRI. I like the iron oxide particles, and I'm trying to get it approved within the next 4 years, and I think I will succeed. It's showing small lymph nodes, but also you can do whole body MRI. And in patients with high risk or intermediate risk, you also can consider the 68 gallon PSMA PET-CT. This provides all the information you need. It will be discussed in the multidisciplinary team, and then the patient will be given an advice, and it will be discussed with the patient what he wants to do. So this is a patient-tailored advice, and then the patient will be sent back to the GP, and he can have his treatment in our hospital or in any hospital in the world. Now I ask you, what do you like more, the first or the second? Well, I'm in favor for the second. There's enough evidence, but again, quality matters, and that's one of the things which I want to emphasize with my presentation. If you are reading prostates, do it well. We are good in detecting significant cancer. It depends on your quality. Be critical, be aware of how good you are. Thank you very much for your attention.